Good evening, everyone. Today is a special day of Iapc. Today is celebration of Iapc. We are fortunate and delighted to have with us the living legend from the field of palliative medicine, Dr. Robert Twycross. 2021 is a very significant year in Dr. Twycross' journey in palliative medicine as he surpasses yet another milestones, the Golden Jubilee year, as he wears the feather of 50 years journey in palliative medicine. Congratulations, Dr. Twycross. India and Indian palliative care community is grateful for your contribution over a period of 3 decades in which you have mentored and taught almost more than 100 palliative care providers all across country. You have traveled all across country, ignoring your personal needs for comfort and irrespective of time and destination where you have to go, without bothering about extreme weather conditions of India. On behalf of Indian palliative care community, I bow my head with respect and gratitude to you, sir. Teaching and training remains your passion along with your writing of another passion. And it was consistent throughout 50 years journey with the palliative care formulary being the flagship publication since 1998, and we all read palliative care formulary all over India and all over the world. We are extremely grateful, and I personally grateful to Dr. Twycross when I requested him that there are more than 40 MDs all over country and they should listen to you for what exactly the palliative medicine. He accepted my request and he has given his valuable time. I welcome once again Dr. Twycross on behalf of Iapc to deliver this lecture on palliative care, what, who, when, and how. Over to you, Dr. Twycross.
Thank you very much indeed. It's a great pleasure to join you today. Yes, I've completed 50 years. The title of the lecture, in fact, comes from the article which is referenced at the bottom of this title slide. And remember that this lecture is not a one-off. It's part of a series of 52 lectures for the fellows, the MD fellows. So it has to be seen in that context. I've given the title that I've given it because of the article. I want all you MD fellows to go away and read if you haven't already. It's open access. You download the whole of April 2020 World Medical Journal, and then you can read online or print out pages 25 to 28. And that's, you know, I want the fellows to do that, and I hope some of the rest will do that. But remember, I'm talking to the fellows. The rest of you, if I can be rude, you're bystanders. So it's part of a 52 lecture, part of a 52 lecture course. Next. 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 Right. Well, that just, we don't have to go into that. That is what Sushma has already referred to, and it was on the advertising for today. And as she rightly said, next. Not only 50 years in palliative care, but 30 years for me personally of collaboration with you in India. I first came in 1991, Bangalore and Bombay, as they were called in those days, and I've been coming ever since, though the last time physically was 2018. And I was there at the first National Indian Conference on Palliative Care in Varanasi in March 1994, when the Indian Association was founded. Yes, March the 16th, tomorrow is your birthday. Congratulations, 27 years old. Have a wonderful virtual conference, Iapc, in a few days' time. Now, what's happened since then, you know, I don't have to tell you, but obviously it's come about because of local champions, myriad initiatives. You fill in the gaps. I mean, you want to put in state palliative care initiatives and so on. You want to put in all sorts of things. You may just want to put in the faces of some champions. It's up to you. All I'm saying is you've come a long way in 30 years, and it's been a great privilege for me to walk alongside you during that time. Next. Now, of course, before I go on, I can't ignore the great pandemic. And I just take my hat off to you, as we say, in admiration for the way all the palliative care teams in India, as around the world, have overstretched themselves, have given themselves beyond their limits to cope with the pandemic, not only within their palliative care centres, but helping specialists beyond to cope with the incredible number of acutely dying patients. I just are full of admiration. I'm just full of admiration for what you have been doing and continue to do. Next. 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 Okay. I'm not quite sure how we can speed up the movement of the slides, but we'll see how we get on. Okay, now in my article, right at the beginning, I list some features of palliative care, which I think are important. But the two at the top, one is that it is holistic, and the other is that it's focused on quality of life. And this makes it different from what is now standard biomedical medicine. Next slide. There we are. Right. Now, if you look at the left-hand side, that's the norm in the acute hospital. We look at our side on the right, and you can see that it is very different. And one of the key things is, of course, that instead of the doctor being the boss, the patient becomes the partner, and we'll come back to that. Next. Now, we must remember that palliative care began as a protest movement against the neglect of dying patients, particularly dying cancer patients. That's where we started, and it is always going to be the central part of our work. But of course, those of us who move from modern acute medicine into holistic palliative care, we have a different attitude, perhaps, than many of our specialist colleagues. And we're not just concerned about the neglect of dying patients, we're concerned about the neglect of other patients with chronic conditions, particularly chronic progressive conditions. And so palliative care tends to expand laterally into these other areas of relative neglect. That means, of course, it depends on country. So palliative care in many ways is country specific, as I point out in the WMJ article. Now, let's have a look at what's been happening in India. Next. Here we are. You may have a slightly different list where you are in India, but this is what the neighborhood network has expanded from end-stage terminal disease right across these other neglected areas. And yes, more than that, as you have too. Next. Up in Chandigarh, for example, but not only Chandigarh, but I thought this was a particularly moving example of how the holistic care, moving to family, how it worked for them. And of course, I know many of you are involved in supporting the families, the children, both before and after the death of the breadwinner. So yes, palliative care expands, if you like, expands to fill the gap in long-term continuing care. But please remember our core calling, if I can call it that. Please go on. Next. So Relationship-centered care. We talk about patient-centered care, better person-centered care, but I think this group in America some 20 years ago hit the nail on the head. We're talking about relationship-centered care because patient-centered care means different things to different people. But we're talking about relationship-centered care, partnership. So yes, fellows, please find this article. Please discuss it between yourselves. It's not an easy read, but those were the 4 key themes which I took out from it. Next slide, please. So empathy. The important thing here is that empathy is enhanced by listening to people's stories. And that emphasizes that you can't learn palliative care just in the classroom. You must listen to people's stories. And I think most of us going into palliative care will have a degree of empathy, and certainly we have the potential for that empathy to develop, and it develops by listening to people's stories. And that, of course, is important for when we talk about teaching others about palliative care, particularly medical students and nurses. We have to include people's stories. Next. So partnership, respect, honesty, listen, explain, shared decision-making, all crucial. Again, it needs fleshing out, and I'm not going to do that at the moment, but respect is so essential. We're treating patients as fellow human beings. When they come into the consultation room, we stand up, we greet them in a way appropriate for the culture, and we make sure they're sitting comfortably and they're relatives, and we're on the same level, horizontal level. We introduce ourselves by name and we establish contact in that way. So partnership is crucial to good palliative care. Next. So it's evident from what I'm saying that communication is the key to good palliative care. And this quote from just a few years ago, in a sense, sums it all up. Ask what matters, listen to what matters, do what matters. Communication is the key. Next. Now, Peter McGuire was a psycho-oncologist, and he videotaped doctors' consultations. And when he reviewed them, he came up with this truism: if you start with the physical, it is almost impossible to move to the psychosocial. So if we are seeking to offer holistic care, we mustn't start with the physical. Tell me about your pain, tell me about the breathing. We must start from where the patient is, which may be there, but on the other hand, it may be completely something else. Next. So in palliative care, when we meet a patient, not only have we greeted them appropriately and so on, how can I help you? How can I help you? Next. Now, I think there are 3 types of communicators in the medical profession. Those who are naturally good. This is a quote from a paper by Cicely Saunders. She discovered way back, in fact, 60 years ago or more, that it wasn't just prescribing morphine every 4 hours that transformed the wards. It needed to be combined with having the time to sit and listen to the patient's story. Now, she never went to a communication skills course, but she was naturally good. But then at the other end, next, at the other end of the scale, you've got the congenitally impossible communicators. And this is happening somewhere every day around the world to patients. And this is focused, of course, on the cancer patient. The patient comes back and the doctor says, here are the facts and figures. The options are, what do you want to do? Now, this happened exactly 2 months ago to a friend of my wife's. She went back to get the result of the scan. She's had, we'll call it grumbling colonic cancer, intra-abdominal cancer for some years. She's had various treatments, lots of chemotherapy. But obviously things were progressing. She had the scan. She comes back and the doctor says, we can do 3 things. One is do nothing and you'll die. Then goes on to talk about minor surgery, defunctioning coloscopy, major surgery, debulking and so on. But we can do nothing and you'll die. Panic, panic. Now you may say that's patient-centered, but it's not. It's not. It's a travesty. And a doctor who was dying of cancer, next, a former editor of the New England Journal of Medicine, he wrote it while he was dying of esophageal cancer, and it was published immediately after. A physician who merely spreads an array of options in front of the patient and then says, go ahead and choose, does not warrant the title of doctor. And he was speaking from personal experience. So the tyranny of choice is what he called it. Next. And then you've got those who are capable of learning to be better communicators. And I include myself in that. You see, you start off by thinking, well, I did, courtesy and kindness, you know, is what it's all about. But courtesy and kindness are important, but they don't add up to good communication. And it was only after 20 years in palliative care that a patient said this to my research nurse, who reported it back to me. The trouble with Dr. Twycross is that he's so charming. Now, fellows, be warned, are you charming? Are you courteous and kind? I hope you are. But remember, if you are charming, you are acting as you're blocking the expression of their fears and anxieties. It's a distancing technique. And I hadn't realized that. But when my nurse reported this back to me, it was like a eureka moment. I realized what I was doing. And you, of course, have already discovered that part of good communication is to express, is to help the patient express their fears and anxieties. Normally, they will not, because they do not want to upset you. You're so nice. We don't want to upset him. So we have to elicit their fears and anxieties. Next. Okay, back to relationship-centered care. Well, if it's relationship, then relationships are based on trust. So the key question surely is, how do we build trust with our patients? Next. Now, Kate Granger was a geriatrician in her 30s. She had ovarian cancer. She had treatments, surgery, chemotherapy over the years and so on. But she was fed up. She was fed up with the fact that so many times people came into her room in hospital and said, I've come to do this, I've come to do that. And they didn't introduce themselves. And she, in fact, started a campaign called Hello, My Name Is. But notice what she said. Introductions begin therapeutic relationships. Introductions can instantly build trust in difficult circumstances. So, fellows, are you in the habit of introducing yourself by name when you meet a new patient? Do you have a big name badge on your shirt or coat so that they can see it even if they don't quite hear it? Do you have a plaque on the desk in outpatients with your name on it? But even if you have those additions, then you still need to actually verbally introduce yourself. Absolutely crucial. You know, not introducing yourself by name is getting off to a bad start. And why get off to a bad start? Because you may never recover. Please go on. Next. So other points about palliative care I want to emphasize today is that it is time consuming, and although it is low tech, it is also high skill. So time consuming. Next. This was a study done in America, and they surveyed various doctors, various centers. What about the initial consultation? And the answers came back. The median time for the initial consultation was 55 minutes. Now, do you have 55 minutes? Well, I raised this question 3 years ago, and I was told, yes, ideally, they would try and give, you in India would try and give 45 minutes. So I think one of the big challenges to you, because I know you often have many more patients than we do in an outpatient clinic. And how on earth do you give 55 minutes to each patient? Now, this is something we could discuss at length afterwards. There are obvious ways, and I believe that some of you do make use of trained volunteers to get some initial information about the patient's social situation and to fill in a genogram, the details of the family, so that when the patient gets to you as the doctor, you've already got something written down which helps get you onto the target straight away. So yes, but we have to give time. And that's part of our responsibility of palliative care physicians. Not to take the necessary time means that we may also get off to a bad start. Next. So low tech, but high skill. Yes, it's high skill. I'm going to say that don't go into palliative care if you are a failure, if you failed in another specialty. Don't think that palliative care is a soft option. It's not. It's high skill. So palliative care is only for successful doctors. You can challenge that, but that's what I'm saying for the moment. Now, part of the high skill is attention to detail. That should be the mark of every competent professional. Asking why. Why is this patient who's got breast cancer vomiting? You know, the cancer is in the breast. Why is she vomiting? Now, obviously, you know there are several reasons, but we have to look at the whole situation and come up with a best answer. In other words, making sure that all the pieces of the jigsaw puzzle fit together. Next. So I'm going to talk most of the rest of my 35 minutes to one or two aspects of symptom management. And this is because I'm talking principally to the fellows. And this mnemonic detailing the steps in symptom management is detailed in the paper, the WMJ paper. And attention to detail, yes, that's the golden thread running through the 2 E's and the 2 M's. Next. So, pain evaluation. Now, in the United Kingdom, I gather that medical students nowadays are generally taught Socrates, a mnemonic to help them to remember to ask about the different aspects of the pain, if I can put it that way, so that they can come with a clear description and not miss anything out. But this is not pain evaluation. It's pain description. It's part of evaluation. Of course, it's important. Next slide. And come with me to the bedside. Here we are. The patient is describing their pain, possibly prompted by me. Tell me about your pain. Where is it? Pain in the back, doctor. Ha. You may be thinking low back pain. The patient may be thinking thoracic pain. So wherever the patient says he or she has pain, say, could you put your hand on it and show me exactly where the pain is? And does it spread anywhere else? Get them to map it out with their hand. Now, you may say that's partly examination. You're talking to the patient, but you're asking them to put their hand on their pain, and you're possibly necessary, if necessary, you're prodding a little bit. But that's how it is. And also, as you'll see, the explanation all fits in together. So the patient's describing it, you're doing a bit of examination and explanation. It all comes in together to a large extent. Now, while they're describing the pain, then you're thinking, well, what on earth is the mechanism? Is it nociceptive? Is it neuropathic? Is it functional? Is it organic? And you're saying, well, what's the cause? Cancer or an alternative? What is the cause? And what about non-physical factors? So you're computing all these other aspects as the patient is describing the pain and coming to a considered opinion. Next. So remember, multiple pains, often different causes. But of course, when you move away from pain to other symptoms, you can only have one breathlessness, one anorexia, one insomnia, but there may well be multiple causes. Next. So, non-physical factors. Here we have, and this is a recent story given to me by a colleague who was working at the bedside until fairly recently. So you've got a woman in her 60s who's been referred to the palliative care clinic, and she has pain all over the body and she's on high doses of morphine. Now, you look at that, you know, if she's got local breast cancer and all the scans and so on and the workup before she had her treatment shows that, there's no way she's got disseminated cancer with disseminated cancer pain. So the palliative care doctor concerned recognized that in talking to the patient, she recognized that the patient was extremely anxious. Now, so the prescription was not more morphine. She was prescribed a small dose of an anxiolytic. Next time she greeted me. Can we go back? That's fine. That's fine. Next time she greeted the doctor with a big smile and saying, that's the best painkiller I've ever had. Now look, she went home with no opioids or anxiolytics. So the importance of taking non-physical factors into account, you can't underestimate it. You can't underestimate it. A doctor who came to work here in Oxford for 6 months way back in 1986, when he went back after working with us, he found that he used fewer, lower doses of morphine than before, because he had moved from approaching pain more as a physical condition to something which had these other aspects to it, including the non-physical. So here we are, the right therapy for the right type of pain. Next, please. So there we are. Probability pattern recognition is, I think, what we're doing most of the time. Informed imagination before more investigation. Next slide. So here's a story some of you may have heard before. It is in fact in an article which was published in the Indian Medical Journal in 2004. and fellows, I would like you to read it. It's one of the references in my WMJ article, so it should be easily obtainable for you. Now, this woman, here she is. She had a laparotomy 10 days before. She was found to have inoperable pancreatic cancer, so she had what we called an open and shut laparotomy. And postoperatively, she was well cared for. She was given injections of morphine and then converted to regular 4-hourly morphine, and the dose was increased from whatever, and it got up to 25 milligrams every 4 hours. But she was still in pain. She was distressed. She had insomnia. She was drowsy. So they called us over in the palliative care unit, and I said, fine, I'll come across on my way home. So I cycled across from one university hospital where I worked to the other university hospital and met her on my way home. Now, of course, I'm tired at the end of the day. There's no way I can give 55 minutes, and perhaps there's no way I should, because there is this quite definite focus. She is in pain. So I say, tell me, can you show me where the pain is? So she shows me number 1. And I said, does it go anywhere else? And so I end up learning about 6 different pains. That's important because most people who have pain in advanced cancer have more than one pain. In fact, it's the minority who only have one pain. So the interesting thing was, those who were caring for her had no idea that she had a fractured rib. And of course, if you try and get the patient up, as you do post-operatively, then you're going to cause great pain as the patient is heaved forward, agony, in fact, and screams. So you end up with a patient who is very distressed. So as we talked about the pain, I said, well, you know, this pain, I think it's incision. This, you know, and I just said what I thought, and there were a nurse in attendance. I said, and this is what we need to do, and talked about the patient being moved in a certain way to minimize the pain from the fractured rib and so on. And what did I do next? I reduced the dose of morphine from 25 milligrams to 15. The patient was in pain, but I reduced the dose of morphine. It was 15 during the day with 30 at night, because I thought more at night would make sense given the insomnia. I also added in a non-steroidal anti-inflammatory drug, a non-steroidal anti-inflammatory drug, and we talked about the management of constipation, the need for an enema the following morning. And I said, I'll come back and see you during my lunch break tomorrow. When I go back 18 hours later, she's sitting up, she's smiling, laughing. The nurses are with her, happily talking. The situation has just changed beyond measure. Okay. Can we go back? Thank you. The situation has changed beyond measure. And we were able to reduce the dose from 25 to 15, as I said, and down to 10 and down to 5 milligrams every 4 hours. We transferred her to the palliative care unit, where she died some 2 or 3 weeks later. So there, I think, is a very good example, which you can repeat as many times as you like, but that's a classic example of patients with cancer pain, multiple pains, and the need for holistic assessment. Next slide, please. Now, this is what we were teaching when I first came to India, and I had worked with a group of people with the WHO to create the method for cancer pain relief, which was finally published in 1986. And I imagine you were taught this or something like it when you came into palliative care. Next. Next. And the analgesic ladder? Yes. But, you know, if I was doing it all over again, I don't think I would have used the analgesic ladder. It was very important at the time because it gave doctors permission to use analgesics, even though most of them only had non-opioids and weak opioids, and it allowed them to advocate for the availability of strong opioids. But I think, as you'll see from the story I've already told you, if you just go on up the ladder and go on building up the morphine, that is not always right. So I would give a different model now. Next. I would say we've got three classes of analgesics: non-opioid, opioid, adjuvant, and some pains respond best to one, some to the other, some need combination, and some occasionally need all three. Yes, non-opioids can be more powerful, if I can put it that way, than opioids. Adjuvants can do in some patients what non-opioids plus minus opioids can't do. So this is the model I want you to take away. Broad spectrum analgesia. Opioids are not always the strongest analgesic for this particular pain. Next. Now, we're over the halfway mark. So now, nowadays, there's a great tendency to score everything. But a score of 0 to 10, as we've already seen from the example of the patient in pain, does not provide enough information about the impact on the patient. So let's just spend 2-3 minutes talking about another symptom, breathlessness. Next. So every patient, new patient, should be asked about their breathing. Now, of course, they've been sitting in front of you or lying in bed for some time, and the breathing may be perfectly all right. So if they say, no problem, doctor, you have to go on to say routinely, and when you get up and do things, how is it then? And if they say, oh, it's bad then, doctor, then question, is there anything you've had to stop doing because it makes you too breathless? What can't you do now that you could 2 weeks ago? Does that frighten you? Next. And here is a crucially important question. You're moving up the scale of questioning. Does the breathing ever get so bad that you think you're going to die there and then? Don't be afraid to use the D word. Do you think you're going to die there and then? And if the patient says yes, you validate their distress. That sounds terrifying. Now, I'm cutting corners a bit, but it's just to give you the flavor. Next slide, please. Listen carefully to what I'm about to say. Look, with each attack, you think you're going to die, but so far you haven't, have you? And I used to go on and say, I can promise you that however many attacks you have, you'll not die in the middle of one of them. You'll always pull through. Next. And this is what I'm going to do. Now, because we've exposed the fear and the anxiety and terror that indeed is going to die in the midst of one of these attacks, then I can now go and say, my own feeling is that you won't get so many attacks now that we've talked about them. But if you do, I think they won't be so bad. Next. Right, and I refer them on to the physiotherapist. Now, finally, can I just say, as you know, it's not always possible to relieve a symptom completely, and in a sense, that's the icing on the cake. The bottom line is helping a patient move from being overwhelmed by a symptom to exercising mastery over it. And the final case history in my Indian journal pain, this article here, that's a classic example of how someone still had the pain, but because of what we did in terms of taking an interest, listening, and 1 or 2 adjustments, it no longer was overwhelming. And he said, well, it's still there, but it's not a problem anymore. And that's what we're doing with anorexia. It's often helping the patient and family move away from force feeding the patient to more accepting. So yes, it's not always possible. Now, finally, before we stop and go to the questions, please, next slide. Something about drugs. There could be a lot about drugs. Now, we were obsessive when we had patients at home or going home about how we gave them clear written instructions. Now, you are perhaps in a very different situation, but I know some of you indeed do give the patient written instructions. I recognize that some of your patients are not highly literate and there may be problems. But the important thing is, unless we give clear instructions of patients and families, we won't have adherence to our recommendations and our symptom management is going to fail. So this is something, if you haven't already, you need to talk among yourselves. How do we give clear instructions for patients and families? Now, next. So there we are. I've just said a few things that I said I would. I've referred you to 2 of my articles, and let's take it on from there. Thank you for listening. Let's go to the questions.
Thank you very much, Dr. Twycross. Thanks a lot. Thank you very much. So Arun, go ahead. Arun has a lot of questions. So participants have sent before, and there must be many questions in the chat box. So Arun, go one by one, please.
Yes, Dr. Twycross, can you hear me clearly?
Oh, yes, very clearly.
Sure. Thank you so much. Thank you for that wonderful lecture, Dr. Twycross. So the first question is, how and when to initiate palliative care in chronic non-oncology disease, for example, chronic kidney disease?
Thank you for that. And one of the problems is, you see, I don't know exactly who made that question. If it was one of the fellows, I'm going to say, oh, weren't you there 2 weeks ago? Oh, the 22nd of February. Practical aspects of setting up a palliative care consultation service in acute hospitals. So that should give you perhaps a lot of the answers which are practical for India. But the question does say, e.g., chronic kidney disease. And I'm going to refer to what has happened here in Oxford, because I think it's very informative. In Oxford, believe it or not, if someone is in severe renal failure and they are referred to the clinic, then they are seen by a specialist nurse. They've already, been either included or excluded by the physicians as to whether they're appropriate for renal transplantation, kidney transplant. So she is looking at those who are not up for kidney transplant. And she says, well, we've got 2 options. We've got dialysis and we've got maximum supportive care. And some people opt for maximum supported care. And that is intriguing because these people who may have a GFR of only 10, some live for 2 or 3 years more and have a surprisingly active life. Now, who offers the maximum supportive care? Well, it's one of our palliative care physicians. Now, how did this come about? Well, you've got younger renal specialists moving into that particular specialty who in medical school have been exposed to palliative care. So they have a different mindset from the people who qualified 30, 40 years ago. And it was two of the younger renal specialists who said, you know, can we have some input from palliative care? And in fact, we'll put some money into the pot. So they were prepared to pay for 1 hour a week of one of our palliative care physicians' time. Well, that 1 hour a week became 2, became 3, became a whole day, and I think it's now up to 2 days because of the value at that service. So if someone is referred for maximum supportive care, they're seen in the renal unit by a palliative care physician, and the plan is taken forward from there. Now, listen to this. Some of the people, some of the renal doctors say, well, don't use the word palliative. It's a nasty word. And the doctor concerned says, no, I insist on using the word palliative. And you see why people don't like to use the palliative, doctors, is because they really are still uncomfortable with the fact that patients are going to die. So I take my hat off to this much younger palliative care physician who says, no, I'm going to use the word palliative, and she insists on that. So you can see this is how it came about. Teach your medical students, the future specialists in other specialties will know about it and will say, we need help. Now that's going to take some time. Anyway, that's how it is. Now in my WMJ article, I do talk about what the oncologists have done in America, you know, 10 years ago almost, ASCO, they have said people with metastatic disease, certainly those with a big burden, symptom burden, they should be referred to palliative care, often to work side by side with continuing non-curative but anti-cancer interventions. So yes, these things develop. They don't happen overnight. So
I will leave.
Next question. You
Yes,
are
thank
muted,
you.
Dr. Twycross.
Yeah, he's muted. I think we can unmute him. Dr. Twycross, you have to unmute yourself.
I've
Yeah, there
unmuted
you are.
myself.
Yeah, thank you. So we are going to the next question. Just for clarification, we got around 60 questions, and we thought that we'll cuddle down the question to around 5 or 6 for the interest of time. And so it is difficult to go to the names of every person who posted the question, but I believe that they are there, people in online platform, and they'll be getting the answers to their question and much more, of course. So going to the next question, the question is, so the medication administration in end of life by caregivers at home, how can we justify it? This question was actually given by Dr. Stanley McAdam.
Well, Stan, I'm not sure why you asked that question, because you know the answer. You can't not justify prescribing medication for the patients who are dying at home. Most of the patients you're looking after are going to be outpatients. They will have been on medication for weeks, possibly months before they die. This is just a continuity. I don't know whether you're referring to the fact that you may want them to give medication by injection. That's only an extension of the basic situation that they have to have the medication. You have to deliver the medication. And if you're relying on them to give the injections, then of course they have to be trained. And in many countries that has proved possible. So it's not a matter of justifying it. It's a matter of saying we aren't justified not giving it. Thank you.
Thank you, Dr. Twycross, and I think Stan, you have got your answer. Moving on to the next question. It's a bit of a personal question for you. So, Dr. Twycross, what motivated you for entry into the world of palliative care?
No, I did take slight objection to this question because this isn't a personal biography lecture. It's mainly looking forward with you fellows. But I'll just say, way back in 1963, as a medical student, I went to a lecture by Cicely Saunders at an international conference held in the United Kingdom. And what she said about care of the dying was inspirational for me. And that was the beginning, and it led to my moving to St. Christopher's 8 years later as her research fellow. So I think most people move into palliative care, or many people move into palliative care because they are inspired by a role model. And I know from the week-long courses we were holding in palliative care for the medical students from the early 1980s onward here in Oxford, that week led to quite a number of doctors saying, I want to go into palliative care. So I guess it's, if you have a palliative care heart and you meet a good role model, then that is going to move you in the direction of palliative care. Thank you.
That was very inspiring, Dr. Twycross. Moving on to the next question, quite important, I guess. So can you tell us something about self-care of healthcare workforce who are working in palliative care?
Thank you for that. Well, we all know about burnout. And of course, if you look at the literature now, it's burnout or compassion fatigue or moral distress. They're all descriptions of something which is slightly different, but they often overlap. And I think they can often overlap, particularly the moral distress in relation to the nurses and perhaps junior doctors working with seniors who approach things very differently. So you've got burnout, you've got compassion fatigue, you've got moral distress. And one thing I'm sure is that many people, including many of you, will have what I've merged together and called battle fatigue, either during the rest of the pandemic or when the pandemic is over. And that is, there's no shame in that. We've all got limits. I burnt out. My first big time was 1985, and I've burnt out several times since. And you can only burn out if you were once lit up. Now, how do we cope with that? Well, there is a big literature. What surprises me in the literature is that they don't say take adequate time off. They don't, what have I said? I'm giving too many double negatives. Okay, these articles so often don't refer to the need to take time off, and they don't refer to vacations. Now, I was lucky. I used to plan 7 weeks of vacation a year. And a lot of the articles, of course, come from America, where I think doctors are particularly bad at taking time off. And you may not be able to imagine taking 7 weeks off, but it's worth taking 7 weeks off. It allows you to work for 7, 14, 21, 28 years. So vacations, time off, however you look at it, is crucial. But yes, you need a supportive environment. You need a supportive environment. I spoke to a senior nurse about, you said, Anne, after I got back from that period of extended leave in 1986, I had 3 months off. You said I was different. What was the difference? And she replied, well, humility. Interesting. And she said, you were very supportive for the nurses after that. So we have to have an environment which accepts that burnout can happen, will happen. We have to have a supportive team where we support each other, particularly the people at the top. So, yes, well, I can't go into more detail because it's a big subject, but just remember, time off is crucial. Life balance is crucial. Thank you.
Thank you, Dr. Twycross. We have the last question for you today. And you have touched upon a bit about the importance of education in changing attitudes of physicians. But in practice, can you tell us about the phases of palliative care acceptance among doctors, particularly working in private sector, that you have seen in your lifetime from other specialties?
Right. Now, that was an interesting tail end, especially in private practice. Now, of course, here in the United Kingdom, the vast majority of palliative, medical care is through the National Health Service. We have socialized medicine. Private practice is small by comparison. Now, of course, once you have a lot of private practice, then, you know, more than medical considerations come into the picture. I'm sorry to say this, but when private practice earns you money in the pocket, then perhaps you're more reluctant to pass someone on to a palliative care team. And this certainly has been the case around the world over the last 50 years and possibly still is. So, yes, I think it comes gradually. I've already mentioned that if you are training medical students, exposing them to palliative care, they move forward in a slightly different way. And of course, in the United Kingdom, we've had one or two scandals of bad end-of-life care over the last 10 years or so. And we've had commissions looking into it to see how we can improve end-of-life care. And that's raised the topic, you know, up to the top of the ladder almost. The public are very keen that that is continued to be thought about and given a certain measure of priority. Now, you may not have had that sort of benefit, but you will have had in many states the state palliative care program. And I think that is perhaps how you can hope to move forward. So medical student education, general public awareness, campaigning for palliative care, and moving towards the state palliative care initiative. It takes time, and there've been changes, and you're going to go on working for more changes, I know, over the next 10, 20, 30 years. Thank you.
Thank you for those inspiring words, Dr. Twycross. We got 2 more minutes. Dr. Bhatnagar, would you like to take few more questions? How do you want to do it?
Yeah, so there are two or three important comments and questions in the chat box. Arun, have you seen those comments?
There are a few questions regarding doctors and how to go about it. We have discussed that. There was a question about counseling patients who seek multiple opinion from many doctors because they are not satisfied with one doctor. How to go about it? There's a question about that. Anyone can, if you want, you can take on it. Shall I?
Well, it's very difficult. It's very difficult for me to comment because I'm not in India, and I understand that is a particular problem for you in India. It's a particular problem when you have so much private practice. But when you have a National Health Service set up, that is less likely, though not impossible. So I'm not going to answer that. And also part of the question, or a parallel question, was about what you do in the time of COVID when you've got protective equipment and so on. I haven't been practicing during the pandemic, so I can't answer that.
All right, thank you. Dr. Bhatnagar, any more questions you would like to take? We have 1 or 2 Indian specific questions.
I think time is okay, 1 more minute. So maybe just I think we can finish it, and then maybe India specific question we will take in the next lecture. Is it okay, Arun?
Yeah, definitely. And we have some questions about pain management and symptom management. We'll take them in the upcoming lectures in IAPC session.
Yeah. So next lecture will be on only on morphine. So please, all the questions those are related to pain management, especially to the morphine, I think we have not addressed. We have tried to cover all the questions, maybe 10 questions in one question, and we wanted to speak your name, but it was really difficult. Almost 60 questions were there, so that's why we have not not named you that who has asked this question. But Dr. Twycross, most of the questions were from young palliative care physicians, those who are doing MD, especially the non-malignant one, and then they were asking about the other question, first, second, third, fourth questions were all from MDs, and definitely because it's a COVID time, so a lot of people have asked question related to COVID, which we have not covered here. And there were many questions related to India specific, so we have not covered those questions also. So we are sorry about those, but definitely we will try to cover in the subsequent lectures whenever and wherever this will come. But before closing, thank you very much, Dr. Twycross. We are so happy, all our residents, they are so happy to see you, and all the doctors, all the palliative care community, almost still there are 230 people are still there, and they all are listening to you, and everyone, I think the whole chat box is full of compliments, and it's going to be natural from their heart. So thank you very much for giving your time, and thank you very much for accepting this invitation. I know this was a difficult task, but I tried, and it was successful. So I'm really happy about it. Anyone, if they want to comment anything, they can open their mic and comment. Yes, please go ahead.
When is the next lecture? When is the next lecture?
Next lecture will be, we do these lectures in the morning, 6:30 to 7:30. But 6:30 to 7:30 morning would have been midnight for Dr. Twycross. That's why this is the first lecture we are taking in the evening. Otherwise, we do in the morning, 6:30 to 7:30. Every Monday, 6:30 to 7:30, we have a lecture.
AM, morning.
AM, yes.
Okay, take. Thank you. Hello.
Yes, please.
Can we get the link again?
Yeah, every lecture we send the link to everyone.
Okay. Thank you so much.
The whole India we send the link.
Okay. Next lecture on morphine, you said.
Basically on opioids, on oral opioids. Yeah.
Okay. Monday morning 6:30. Okay. Thank you.
And can I just say that I very much hope it'll be possible for the fellows and for others to have a copy of the slides. I don't know how you do that, but I'll leave it with you. I'm very happy for them to have the slides, and it may help them to follow up and continue the talk among their own groups.
Dr. Twycross, all the slides of these lectures are there on the IAPC website. So all the collections of all the lectures is there on the website. So there is a library on the IAPC website, and all the lectures are stored over there. So anyone wants to open any lectures, they can open.
Okay, nice.
So
thank you. Thank you.
I think everyone is speechless, and if anybody wants to comment anything, Dr. Michael, you are there?
Yes, hello. I'm here.
Yes, please.
No, I would only say I always learn something when I listen to Dr. Twycross.
Yes, even I have learned a lot today. Thank you very much. Thank you. Dr. Stanley, Dr. Rajam.
When are you coming again, Dr. Twycross?
I think my traveling days are over. As you can work out, I'm now over 80. My health is not good, even though I can perform for 65 minutes on occasion. But traveling to India is certainly something in the past. But, you know, I keep in touch with various people and it's great. But coming to India, no.
I guess we'll have to come there.
Maybe.
Hello,
Yes, Dr. Sukhdev, yes, please go ahead.
Dr. Twycross, good evening.
Lovely to see you.
I heard you in a month of August 1991 at Kidwai.
You did indeed.
Yeah, and Dr. Vijayaram was there, and a lot of pioneers are there, and it was a learning experience. Today also we learned many other things like human values and balancing, so many things. And if you cannot come, this is a very good platform that even if you are staying and interact and add questions, that's good. If you cannot come, the medium are there. Maybe I'll request Susma to arrange more frequent lectures with you, that we all, including we still are students. We are still students of palliative care, and I feel it is also a learning point for me. I can take myself as
Dr. Sukhdev, your internet is not stable.
lectures.
Can't hear you. So, in the last.
Twycross. Hello.
Hello, Dr. Manjula. Yes, please go ahead.
Hello, Manjula. Hello.
How are you, sir? I can distinctly remember every single minute we spent with you in Oxford, sir. How are you, sir?
Well,
And
as I
doing very well with your blessings.
well, as I said a few minutes ago, my health is not good, but I still live a fulfilling life. And it's lovely to see you. And I well remember visiting the hospice whenever it was in the mid-1990s.
Yes, sir.
And that was a great occasion.
The first workshop in Tamil Nadu was by you, sir, in 1991. Soon after you came to, I met you in Kidwai in 1991. I hope you remember.
Well, sometimes my memory is a little bit vague, but I can't forget you.
But yes, sir, you are our guru, sir. For all
Remembering
of us.
your visit in 2016 BC in Kochi.
Oh, I remember. I remember.
BC means before Corona.
Yeah. Anyway, there we are.
Dr. Twycross, the last comment from any PGs, the fresh PG, Sanjeev, Chandupriya, anybody wants to say that how they are feeling today? One PG has asked, what is the future of palliative medicine? So this was...
The future of palliative medicine. You know, death is 100% certain. We have a great future. Now, you may think that's a bit flippant, but the fact is, you see, way back in the 1970s, late 1970s, we said, well, when we've trained the medical students, when we've trained the next lot of doctors, we'll be doing ourselves out of a job. But I can tell you, we will never do ourselves out of a job. The majority doctors are not happy with death. And we have to, in a sense, hold their hand. You know, I was at an outpatient clinic as a patient, a cardiac, a couple of years ago, and the cardiologist said to the medical student who was in attendance, we get a lot of benefit from the palliative care team. And I said, could you tell the medical student exactly what is the most beneficial? And there was a pause, and then he said, conversations about end of life. Conversations about end of life. And that's one of the things I think you'll find that even in 20, 30 years' time, many doctors will still be asking us to have that difficult conversation. No, palliative care has a future. It'll always have a future.
Thank you very much for encouraging MDs. I always say that after 10 years, it will be the #1 branch for everyone who wants to take. After clearing their NEET PG, they will like to take first #1 branch will be palliative medicine after 10 years. So it will take 10 years to become number one, but definitely it is improving. The
ಎರಡು
state
ಅನ್ಬಿಡ್ಬೇಕು
is improving.
ಇದು ಮಾಡಿದಾಗ ನಿಮ್ಮ ಕ್ಯಾಮ್ರಾ ಬರುತ್ತೆ.
So anyway, Chitra, Sunita, anyone wants to say, and then we will. We are
Robert,
shooting time today, but it's okay.
Robert Chitra here. It's so good to see you.
Good to see you, Chitra.
How's Deirdre doing? I hope all of you are well. And
We're getting two off target, but Deirdre is very well. Thank you very much, and good to see you.
yeah, I mean, I was just, Rajeshri had just posted, how we got initiated into palliative care with your foundation classes and how the journey had continued. And I had also the privilege to spend time with you in your house in Oxford. So all blessings. Good to see you today.
And every blessing on you and your continuing work.
Thank you so much.
Hello.
Sunita and Dr. Veena George is also there. So Dr. Veena and Dr. Sunita.
Hello. It's so wonderful to see and hear you again, Robert.
Hello, Reena. Good to see you too.
It's really, tears in my eyes, and to hear all that wisdom distilled in your inimitable way. And you must be feeling so happy to see the legacy of your trips to India today.
Well, clearly, yes, very, very impressed. It was a slow start, but over the last 10, 15 years, it's been a gathering momentum. And it is wonderful that you not only have the MD fellowship program, but also the fellowship program of the Academy of Palliative Medicine. All very impressive.
Thank you.
Sunita?
Thank you very much, ma'am. Thank you, Dr. Twycross. I've not had the privilege to meet you in person. My name is Dr. Sunita Daniel. It was a pleasure listening to you. I've heard lots about you. And thank you very much. Thank you, ma'am, for the opportunity. Thank you.
Well, thank you for being with us. Thank you.
So last from Raghav, one of our PG student. Raghav, please say, how are you feeling today? All of you, on behalf of all the students.
Good evening, sir. Good evening, ma'am. It's been a wonderful experience listening to this whole talk. Even though I could meet you only once during the AppCon in 2018 when you came to India, but all in all, it's been a great experience listening to you on the online platform also, sir. So on behalf of all the residents from my department here at IRCH AIMS, I would like to thank the IAPC as well as you for giving so much of insight into this beautiful branch.
Thank you. Thank you. My pleasure.
Dr. Sushma, if I might just make another small comment.
Please go ahead. Today we will not worry about timing. So we are.
No, another thing I just wanted to mention is that when the Indian Journal of Palliative Care was very young and did not get any articles, Dr. Twycross would write an article for each issue, and his articles could have been published in the topmost journals, but he would do it for IJPC, and it's just one small example of how he pays attention to the smallest and the most needy.
Yeah.
Thank you.
So
I enjoyed it.
We remember everything, Dr. Twycross. Everything we remember. Everybody is now today is emotional after seeing you and your lecture.
Well, maybe that's a good point to conclude, but it's up to you.
Yes, I think we can conclude because we have taken 13 extra minutes from you. So thank you once again on behalf of Indian Palliative Care community, on behalf of IAPC, and on behalf of all youngsters, those who are listening, and for giving this opportunity. Thank you very much.
Thank you. Thank you.
Thanks a lot.